Join the PRS Journal Club. Read the monthly picks and classic pairings on PRSJournal.com. Discuss with the authors on Twitter at PRS Journal and listen to the podcast.
Hi, everyone, and welcome to the December 2017 special Masters edition of the PRS Journal Club podcast focusing on craniofacial surgery. My name's Chad Purnell, PRS Resident Ambassador from Northwestern, and as always, I'm joined by my co-resident ambassadors Shuja Shafqat from Fox Chase Cancer Center and Jordan Frey from NYU. Today we have the honor of being joined by Dr. Jeff Fearon, Director of the Craniofacial Center in Dallas and an Associate Editor of Plastic and Reconstructive Surgery. Thanks very much, Dr. Fearon, for joining us for the special Masters of Plastic Surgery edition of the PRS Journal Club podcast.
Well, thank you, Chad, for your kind invitation.
So the article we'll be discussing next is postoperative intensive care unit care necessary following cranial vault remodeling for sagittal synostosis? From Drs. Wolfswinkel, Howell, Fahradya, Azagoli, McComb, and Urata from the University of Southern California. Remember, all of this month's articles can be read for free on prsjournal.com, including an archive of all past Journal Club articles. As a quick introduction to this article, sagittal craniosynostosis is often treated with cranial vault remodeling, which is a safe procedure, but one that does have risks of significant blood loss, transfusion, and can in rare cases have serious postoperative complications. Most patients across the world are sent to an intensive care unit after this procedure. The authors sought to determine the cost savings and safety of sending sagittal craniosynostosis patients to the ward postoperatively rather than the ICU. The authors performed a retrospective review of all of their isolated sagittal craniosynostosis patients who underwent cranial vault remodeling from 2009 to 2015. Patients that had significant medical comorbidities were excluded from the study. These patients went through a standardized pathway in which they were discharged on post-op day 3 to 4. They went directly to the ward after surgery with no stop in the intensive care unit unless they had a significant complication. They were brought to the ICU. Complications during different phases of hospitalization were recorded in order to determine whether there were changes based on where the patients went and where the complications occur. Overall, there were 110 patients that were included in the study. Their mean age of operation was around 7 months, and 89% of these patients were sent directly to the general ward. There were 9 patients admitted over the course of the study to the ICU from intraoperatively, and there were also 3 that were admitted to the ICU due to events in the PACU, but none that went from the ward to the ICU. There also was a 100% transfusion rate amongst these patients. So amongst the patients that went to the ward, there were no major complications while they were an inpatient. There were 5 patients that required a transfusion postoperatively, and there were also 4 minor postoperative complications and 1 readmission. So their mean costs for a patient that went to the ICU were about $40,000 for the hospital stay, and the mean for ward patients was about $20,000. In the discussion, the authors discussed that significant advances have been made in anesthetic care for cranial vault remodeling patients, which may minimize the need for postoperative ICU stays. They do note that they have a specific floor that's used for these patients that sees them all the time, and so that may change some of the results comparing this to other centers. In the literature, there's about a 0.1% risk of major morbidity or mortality from craniofacial procedures, and thus the authors conclude that we should reevaluate the need for the ICU in uncomplicated cranial vault remodeling patients. I thought this was a really well done paper. USC is clearly a very high volume center, and they've developed a pathway that really works to take care of these patients without an ICU. I think the most important thing to note about the study, though, is that they have a specific ward with a specific pathway that's used to seeing these patients, and therefore the nurses know what to look for if there are problems, they know who to contact, and these nurses are specially trained. I think in the setting of a ward such as that, ICU care can be eliminated in a lot of craniofacial surgery, cranial vault remodeling patients. But I don't think the takeaway of this paper should be that you can just send any vault patient into any floor in the hospital and that they're going to be fine. I think that if we keep a low threshold of transfer to the ICU, if there are intraoperatively or intraop or post-op issues, then I think this pathway makes sense. We've been doing this at my institution at Lurie Children's for a year now, and this has worked out pretty well. But I think overall, it's just important to remember that this is a specialized ward. This isn't just sending these patients to a floor without training for the nurses and without specialized care. Dr. Fearon, I just wondered, what were your take-home points from this paper, and what did you think of this paper?
You know, when I think about our own patients, and we send everyone in Dallas to the ICU, there almost none of them have events that require ICU care. Now, there was a great paper out of Boston that Dr. Gobi published in Anesthesiology a couple years ago, and they looked at how many patients in the ICU required ICU care, and they found it was about 15%. But I think it's important to put this paper into perspective. The authors are not telling us that it's safe to send patients to the floor, because their study design can't show that. What they're telling us is that their decision as to which patients to go to the ICU and which should go to the floor was pretty good decision making, in that none of the 89 patients that went to the ward required transfer to the ICU. So they're pretty good at determining which patients require ICU care, because 11% went to the ICU, and which did not. The second question we have to ask ourselves is, what is the incentive to send a patient to the ward? It's basically to save money, right? And hospitals get reimbursed a fixed amount of money for each diagnosis code. So when we send patients to the ward, we're helping the hospital make a little bit more money. But the bigger question is, are we best serving our patients? If the incidence of, the mortality rate's 0.1%, as you mentioned, there's a paper that Marcin Chervinsky wrote. The question is, how many patients do you need before you might pick up some patients that didn't do well on the floor? I don't know, you guys probably are too young in your training to have heard stories, but I've certainly heard stories of children who have undergone strip craniectomies that have died on the ward from bleeding that wasn't picked up and recognized. Now, these are isolated anecdotal incidents, and I don't have a good denominator to tell you what the risk of that is. And one of the great things they have at USC is they have a 3-to-1 nursing ratio, which at our hospital, it's 5-to-1 on the floor. So those are kind of key points to put in perspective. And I think the last thing we have to consider in making that decision is there are certain medications, at least in our hospital, that cannot be given on the ward that can be given in the ICU. For example, we put all our patients on a Precedex drip because we use a non-narcotic protocol afterwards. And my hospital doesn't allow us to run Precedex on the floor. But clearly, this article shows they're pretty good, at least within the relatively medium-sized numbers, at deciding which patients need ICU and which don't.
Thanks for that. I think those are some really good points. And I think, as you said, there are a lot of different motivations to take patients to the ICU and take patients to the ward. And I think the study isn't necessarily generalizable to other institutions. One other question I had for you was, I thought it was interesting that the authors used this ward protocol for sagittal cranial vault remodeling, but they send all of their frontoorbital advancements to the ICU. So in your mind, I was just curious, do you see really a difference in the complications that these patients have that a total vault remodeling for a sagittal craniosynostosis would be less likely to require an ICU than a frontoorbital advancement? And what driver of that do you think might exist?
It's hard to know. It's a great question. It's hard to know what the authors are thinking because they didn't explain it in their paper. The technique they were using for sagittal synostosis, they said was the same as first described by one of the authors, Dr. McComb. And that procedure, if you're not familiar with it, is kind of basically an extended strip craniectomy, although they're taking some of that bone and putting it sideways to kind of hopefully keep the parietal bones out. And there may be less bone removed in that case than they might do with a frontal orbital remodeling. So that might be one explanation for why they saw a difference. When we look at our own patients in Dallas and compare the frontal orbitals to the posterior remodelings, our blood loss and length of surgeries are pretty similar. So for us, I don't think that would make a big difference as to whether or not we send someone to the floor.
Sure, that makes sense. Jordan, what did you think of this paper?
I thought it was an interesting paper, and, a lot of the points that I wanted to hit were discussed. Here, in general, we'll send these patients to the ICU overnight, and then they go to the floor the next day, and I can't really think necessarily of events in the time that I've been here, which is obviously a fraction of the cases. But so it was interesting to read and think about how it could be generalized to our institution and others. And I think you're right. Like, it requires obviously a place with a good nursing ratio and nurses that are really, really comfortable taking care of these patients on the floor. But it provides a lot of interesting things to think about. Dr. Fearon, what I was interested in asking is what specifically was your intraoperative and postoperative protocol regarding blood transfusions for craniofacial procedures in children such as this? Because I know everyone kind of has a little bit of a different bent on this.
Our decision whether or not to operate depends a little bit, or varies, I should say, with where we are in the procedure or postoperative course. So during the surgery, it's a shared decision with anesthesia. But I'll tell you that our protocol is all patients under 18 months of age. We try and get them recombinant erythropoietin and supplemental iron before surgery. Not only does this raise hemoglobin levels, but it also might make the blood slightly more hypercoagulable. And then the second part of our protocol is all patients get a single bolus of TXA before surgery, which has been shown to reduce blood loss. And all patients we use a cell saver on, so we're recycling their blood and giving it back to them during surgery. I think probably the biggest safety issue we do is we have slave monitors, so I can see what anesthesia sees during the case. And I found this really helpful. I used to think if they were scrambling behind the anesthesia screen to give blood products or something, that they kind of got caught with their pants down. And today I think I was not pacing the operation in the correct way. So when I'm looking at the anesthesia monitor, if I see they're turning down the inhaled agent levels and the mean arterial pressures are coming down in the upper 40s, I know the patient has a low volume status, and I just stop operating. We're not going to take and do another craniotomy at that point. And we just get resorbable bone wax out and stop all the blood loss until either the cell saver can give them back a unit or the anesthesia can get caught up before you proceed with the operation. So that's really helped me to pace the surgery. Using a cell saver also gives you an ongoing, very accurate estimate of blood loss, because every time you get a bowl, you know you've lost 110 cc's of whole blood. So our decision in the operating room is basically, if it's early in the operation and it's getting down in the low 7s and you have more craniotomies to do, you may as well consider giving blood. But if you're at the end of the operation and you're at 7, then we'll hold off until we get to the ICU. And this has become, some anesthesiologists will give more crystalloid, which makes the hemoglobin level seem lower, and then they stay pretty stable. If the other anesthesiologists may give less crystalloid, and then you're going to have to give blood. So we'll follow it more conservatively. Early in the ICU stay, if they get down below 6.8 or 6.6, we start giving blood. But if it happens at 5 or 6 in the morning the next day, when they're less likely to bleed and they're more stable, then I think I'm less likely to give blood. So it's kind of a moving target depending upon how far they are out from surgery.
Thank you. That's really helpful to hear. I think it's a great point you made, working together with anesthesia and having those slave monitors to be able to see and react together. So I think that was really important. Shuja, what did you think of this article?
I agree. I thought this was a very interesting paper, and certainly, attempts to challenge some of the mantra that we learn in our training and our residency programs. I agree with what Chad said about the protocol. Clearly they have a very standardized protocol, and that in and of itself does take some time to kind of develop and take footing, and sometimes that occurs over years. So one thing I would have liked to know is how long it actually took the authors, how long they had been doing the actual procedure, and how long did it take to start developing this protocol and sending the patients to the floor in their institution. I think that's important because, just like sending free flaps to the floor versus the ICU, it takes time for that protocol to get developed and for nurses to get adept at recognizing those issues before they actually become problems. So the longer, obviously, that has been in place at their institution, the less likely that poor outcomes will occur, as opposed to institutions who don't necessarily do it as frequently and maybe don't have such a routine down. And, like they said, they have a special floor. They have nurses that are used to taking care of these patients, a low nurse to patient ratio. So clearly all that kind of plays a role in that. But again, I thought it was an interesting paper. I applaud the authors for kind of trying to break away from the norm. Dr. Fearon brought up some really good practical points about what is this article really showing in some of the nitty-gritty details. So I thought that was really interesting. So Dr. Fearon, for you, kind of going along with the protocol issue, For a lot of these complex procedures, whether it's craniofacial or even in other parts of plastic surgery, clearly protocolization is a way to keep things consistent, reduce the risk of things being overlooked or complications arising. Does this paper tell you that these procedures should be only performed at high volume centers of quote unquote excellence that can reduce complications and decrease costs by monitoring these patients on the floor? Or does it tell you that, these can be safely performed at any institution that has a good experience of doing them?
The first thing we have to say is just because you're at a high volume center doesn't mean it's safe to send someone to the ward. I think what USC has is a really experienced floor with 3-to-1 nursing, which is different than a lot of other wards in other large volume centers. So I think they've really figured this out, and that model is not reproducible to other high volume centers. But of course, I would agree with the statement that a high volume center, if you're doing a lot of these cases, then the general metrics should improve. You should have a little fewer complications and a little better outcomes. There's been a ton of papers examining surgical outcomes for all sorts of procedures that show lower complication rates and better outcomes. But here's a thought. If cases are only done at a few high-volume centers, then fewer surgeons are doing these cases. And I suspect there would be less innovation. I think it's possible for surgeons at lower volume centers who are really careful, if they're very interested and they're staying on top of the latest developments, that can get excellent results at lower volume centers. It really speaks to the key critical factor, which is the judgment of the surgeon doing the case. But then again, high volume centers, everybody that's going to come in touch with the child, the anesthesia, the nursing staff, the intensive care docs, do have a greater level of experience, and so that gives you a little safety benefit. But I wouldn't be in favor of only performing these at high volume centers.
Great. I think those are good points, and kind of looking at both sides of, high volume centers of excellence where, in all parts of surgery, there's been a kind of push to certify certain centers that do a high volume as centers of excellence and therefore places where patients should go. It doesn't necessarily mean that you may get better care there as long as the surgeon, is keeping up on the latest developments and such. But like you said, all the other ancillary staff or all the other people that might come in contact with a patient have also gone through this and have a high experience, which may not be the case at a smaller volume center. So I thought those were good points. So Chad, I'll turn it back to you.
I think that was a great discussion, and thanks a lot, Shuja. And I think with that, we'll end the discussion of this article. Remember to tune into the other 2 articles we'll be discussing on this month's podcasts, as well as all of our previous and future podcasts that are broadcasted every month. Also, don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles' authors. This is our last month doing this PRS Journal Club podcast as the resident ambassadors. And next month, we're going to be handing over the reins to next year's ambassadors, Francesco Egro, Ira Savetsky, and Nikki Phillips. I know that they're going to exceed all of our expectations, and we'd really like to wish them the best of luck, and I know they'll be fantastic. Thanks to PRS, and thanks to everyone who makes this podcast possible, and most of all to our listeners. And Dr. Fearon, thanks again. This has been a great discussion. We really appreciate you joining us for this Masters Edition PRS Journal Club podcast.
Well, thank you, Chad, for your kind invitation to join you.